Welcome back to Wellness Wave Radio. Thanks for tuning in this morning to ride the wave with us. Each week our goal is to give you at least one suggestion that will make your life a little better. My name is Phil George. I'm a clinical biochemist, a certified personal trainer, and a health coach. Please remember, everything we discuss on the show is for informational purposes only and should not be taken as medical advice. So we have a really good guest with us today. So can you please introduce yourself?
Yes, my name is Ammar Humayun. I'm a vascular surgeon with the Vascular Care Group in Worcester, Massachusetts.
And I think this is a really important show, and we talked actually before the show, and I think everybody would agree with this. And, you know, I also have a radio show, and so we have a lot of people over 60 years old, and we have the number one fear that most people have as they age is not cancer or a heart attack, it's what it is, a stroke. In fact, interesting, I gave a bunch of seminars for a veterans group, and actually the executive director there, he had strokes in his family. He was petrified of having a stroke. And he jokingly said with his kids, he says, my gun's over there. If I have a stroke, I don't want to be a veteran, just put a gun, you know, put a bullet in my head. It's just, nobody wants to be a burden on their family. And we've had, in fact, Art, the station manager, he had 90% blockage. And Art said it was okay to use his name. And if, in fact, your colleague, Dr. Roos, was on the show. In fact, I think Art only had one done at that time, and Dr. Roos was here. In fact, what happened, Art was mentioning he was having trouble with his vision. And so Dr. Roos said to him, in fact, Dr. Roos knew his cardiologist. He says, call the cardiologist because you could be having a partial stroke. So these are all little things. In fact, when we get a little bit into strokes, you were saying that it can present in a lot of different ways. So what are some of the ways that can present?
Yeah, absolutely. But to kind of just start from the basics. So you have arteries that go to your brain. They're called the carotid arteries, and they go directly from the heart. They supply the brain. So a lot of times when these carotid arteries, if they have disease, which we call to as in fancy terms atherosclerosis, plaque, and if they develop disease, sometimes what happens is this plaque can basically embolize, which means it breaks off and it goes to your brain, causes a stroke. Now, stroke itself, it's very variable. We see, so it's a wide range of symptoms that you can see with a stroke. Sometimes you can see, as you mentioned, blurriness of vision, loss of vision on that same side. Sometimes you can have more findings such as weakness in your arms, weakness in your legs. And if, unfortunately, sometimes if it's a massive stroke, you can have much severe symptoms like paralysis even. So it's a wide variety of symptoms that you can have when you have a stroke. The importance is to figure out how to prevent it and how to treat it if you do have that disease, which is kind of where we come in as vascular surgeons, is to make the diagnosis and then treat the carotid artery disease.
Right, and I think when I used to work in the hospital, and we would have somebody coming in and they stroke on the way, and one of the things the EMTs do is they basically put an IV in you and they put an anti-clotting thing in there, right? So it doesn't, so the sooner, and I don't know how long can you really survive, can your brain survive without oxygen? It's a very short period of time, right?
It's a very short period of time, and the thing that's unique about the brain cells is that the damage to brain cells is irreversible. So every second, every minute that you don't have oxygen supplying your blood flow, those cells are dying, and those cells, kind of like the cells of the heart, they don't regenerate. They don't, once they're gone permanently. So it's very important to treat these patients as soon as possible. In fact, and the neurologist can talk about this in more detail, but there's a certain time window that you have to get to a patient who's had stroke symptoms within 3 to 4.5 hours. But the most important thing is if patients have, we see this pretty commonly, it's something we actually treat almost every week. We see patients every week in our office with disease, and we keep an eye on it too. But the important thing is when they develop a certain level of disease, which is usually around 70, 80%, then we got to talk about doing an operation to actually take out that plaque or fix it via a stent or something to prevent the stroke from happening.
Yeah, I kind of said it's kind of like the roto-rooter. They go in there and they kind of clean it out. The other interesting fact that I found is actually it's a big thing now with men with ED, erectile dysfunction, and I like to call it the canary in the coal mine. So if you get small blood vessels, you know, in your penis, or even with ophthalmologists, and I look at your eyes, they can sometimes see with the camera when they take the picture, they can see that it's closing up. So they used to do it with the canary in the coal mine with miners. They would put the canary in there because the canary's dying. So it's kind of telling you there's something going on. So if the men out there, if you're having trouble with ED and things like that, it could be a symptom that you could be having arteriosclerosis in other arteries, right?
Well, that's an interesting question. I've never actually had anyone ask me that before, but that is a little different, and not necessarily everything could be related to the blood vessel as well. So as far as erectile dysfunction, whether lack of blood flow can cause it, I don't think it's as straightforward as that. There's a lot more things that go into nerves, medication side effects, a lot of these other things as well.
Right,
because we've never done a procedure to improve blood vessels that directly. Now there are other arteries that supply the penis, for example, blood vessels that go from your big blood vessel from your belly, and sometimes when we treat those symptoms improve as well. So if you have a blockage in your artery, which is called the iliac artery, which is in your belly, because if we end up treating that, sometimes that actually improves those symptoms as well.
Well, the other thing, as I was mentioning earlier, is going to have a radio show, and had somebody call in. In fact, they went to your group, and in fact, I sent over the audio to your group, and he called in and he said that he had DVTs. We'll talk about that, deep vein thrombosis, and they kind of fixed that up, and they said, oh, by the way, why don't we look at your carotids? Looked at the carotids, he had a 90% blockage. Right in, get them right in and clean that up. And he said that wasn't done. In fact, it was done in your group, and he gave you high praises, by the way.
Yeah.
So in terms of, so I think it's really important. And the other thing I've found out is that, unfortunately, unless you're having symptoms, most insurance companies are not going to pay for it. So as I was mentioning to the crew, is one of the issues is I want to know ahead of time that I got the blockage. I don't want to wait until it's actually happening. So the other thing we had talked about, so if your insurance company doesn't want to pay for whatever reasons, I talked to Dr. Roos and said maybe if you want to contact your group, they can maybe get you in and try to find a way for the insurance to pay for it. But if not, I think it's a minimal cost. In fact, interesting, I just had it done Monday. In fact, I had it done Monday because I was going to take my own advice. I was telling everybody else to do it, and I had no symptoms of anything. But I said, I want to know. I'm going on 80 years old. You know what I mean? I'm wondering what's going on over here. It's a really simple procedure. It's basically just put a little gel on there. It took like 15 minutes, bing, back and forth. And Dr. Risk came in and said, good news, you got 0 on this side, and I didn't understand it. Correct? Explain this to me. They said 1 to 50 on the other side, so they couldn't come up with an exact number, huh?
Yeah. So the way we quantify how significant the disease is, we give a range. So we usually go either less than 50%, 50 to 59%, 60 to 69, 70 to 199%. So we always give a range because it's very tough to quantify exactly what the percentage is. So we give a range and then we tailor our treatment based on that range. So that's probably what that meant. The thing about going back to the DVTs and stuff, that's a good point you bring up, because that's also very commonly something that we see really on a weekly basis. We'll see someone, all of a sudden they have pain in their leg, and the pain in the leg, again, could be due to a lot of things, but sometimes it could also be due to a blood clot. So it's very important to at least make sure that that's not the diagnosis if you have leg pain. And a lot of times we do exactly what you just said, what they did on the neck. They do an ultrasound of the legs. It takes 10, 15 minutes, very quick. And with the ultrasound technology now, without doing invasive testing, without doing a CAT scan and all that fancy stuff, we're able to tell right on the spot if there's an issue there in the blood vessel.
Now, how would you treat a DVT, deep vein thrombosis? What's the treatment for that?
So usually the mainstay of treatment is a blood thinner. And there's a lot of blood thinners out there, which we would go into detail if we had time. But basically the treatment is blood thinner. Now, if someone has a DVT in their groin region, or if the blood clot is even higher up, there's another thing we do for it. It's called thrombectomy, where we actually, kind of like the Roto-Rooter you were referring to earlier, we suction out all that clot. And we take out that clot, and again, that's through tiny little incision on the groin or behind the knee, and the procedure itself takes 30 minutes to 1 hour, and patients walk right after. So it's a quick recovery, it's a quick procedure, and it has a lot of stuff in the data that improves the long-term outcomes for this.
And if I had a DVT, because I know there's issues, obviously, but it's Coumadin, what they normally give people, right?
So Coumadin, they've always done traditionally in the past. The problem with Coumadin is you have to keep your levels monitored and you have to get frequent blood work, sometimes weekly, to keep your blood thin to a certain reference range. So Coumadin is usually reserved for patients who cannot tolerate any other sort of blood thinners. Now, it's just you pop a pill and that's it. That thins your blood. So there's a lot of good medications out there now that you don't need this frequent monitoring for. And we prescribe it all the time actually for our patients.
I mean, if I had the DVT, I would think I don't like taking medications. I would think I wouldn't ask you to just go in there and take it out.
Yeah, no, that's absolutely a good question. But again, so if your DVT is low, if it's below the knee, if it's below the groin area and stuff, taking it out is number one challenge to do, and it doesn't really make much of a difference in the symptom. So that's why we don't usually take out DVTs when they're in the legs. And a lot of times if you start the blood thinner right away, that treats the problem nicely and patients do very well. But when you have it in the bigger veins, which are in the belly and the groin area and stuff, there's a lot of literature that shows it's good to take out that because the clot is much bigger. It can lead to more symptoms. It can lead to ulcers, a lot of issues down the line. So that's the part that we actually suction out. It does sound nerve-wracking that, hey, you can't suction it out. You just be on a blood thinner, but that's helps in 99% of the cases.
Well, the other thing, correct me if I'm wrong on this, I'm thinking too, is that one of the reasons why people get in their legs, because obviously you have no heart in your legs pumping it back, so you need muscles, right? You need the muscles contracting.
Absolutely.
to push the blood back up.
Yeah.
That's one of the reasons why exercise is so important, especially walking, because what happens is you're squeezing and keeping the blood going, because otherwise it's going to pool, right?
Absolutely. I mean, you explained it perfectly, and that's why every time we have a patient with any sort of venous issues, meaning their valves are leaky and they're not working, I always tell them, hey, you got to exercise because you got to get those calves pumping. When those calves are pumping, that blood is going back up, all your symptoms do so much better. And in fact, a lot of the times, again, this is delving into another topic of leaky valves, but we'll have compression stockings for a lot of these patients. So that's another common thing we deal with, leaky valves. And we'll tell patients to wear those compression stockings. It compresses that vein, pushes that blood back up to the heart, and they do so much better.
There was other interesting studies. They found out that actually leg strength is one of the key indicators of healthy aging. The stronger your legs are. Another interesting study, they did identical twins, and what they found out, the twin with the strongest leg strength also had better cognition. It kind of makes sense, right? Because it's getting the blood up the bit. So they were finding out that leg strength is so important as you age. And just for the listeners out there, what you can do, as I like to do, is what I call exercise snacks, just throughout the day. If you just do squats back and forth, because the largest muscles in your body are your quads and your glutes.
Absolutely.
And what happens, and again, you don't have a heart down here, so you're going to be pushing it back up and over again. And that's one of the reasons why walking is so important, because you're doing that. And they also found, in terms of it, and I don't know how this is related, they found out that men that walk more often have a lower incidence of prostate cancer. And they don't know why that is. They can't find out why it is. For whatever reason, we're bipeds, right? So, I mean, we're made to walk. So if you keep walking, just simply walking, I'm assuming can also help with the valves in your...
Absolutely. No, absolutely it helps. But, I'm thinking of maybe I should get a squat rack in my office too. Just do some squatting in between seeing patients. That's a really nice idea.
What I call basically, I might just do it. But it's exciting for people just doing this, and this is pretty easy to do throughout the day, it's called exercise snacks. All you're going to do is do maybe 10 of these. Then most people have counters, and you can do just push-ups like this. You don't have to go to the gym if you just do that on a regular basis. So that's one clue to kind of make your life a little bit better is basically just do these exercise snacks throughout the day. So this is, like we talked before, we don't want to put you out of business, but if you do this preventative stuff on a regular basis, it can make a huge difference in your overall health.
I think prevention is the best cure. If you can prevent disease, then that's perfect. Less visits to the doctor, less things we need to do and stuff. So yeah, I mean, I 100% wholeheartedly agree that the prevention is, in fact, a lot of these patients who we see on a regular basis, the reason they have this plaque buildup and the disease is because of smoking. So every time we see these patients in the office, we're always talking to them about, hey, you gotta stop smoking, you gotta try alternate therapies, some, all these medications out there that can really help you quit the smoking so you don't develop disease that we need to intervene on.
Right. It was interesting because we had a Fallon Rehab on the show once, and one of the gentlemen that worked there, he was obese, and I went and we talked to him a little bit about it. He was a desk job all the time. Sitting is the new smoking. Okay.
Yeah.
And I mentioned the exercise snacks. I said, he said, yeah, I can do that. I can get up. I'm on the computer. Get up. So if you got a desk job where you're constantly sitting, just set a little timer or something. Get up every hour or whatever. Do your exercise snacks. Do your little push-ups here, and anybody can do that, and keep the blood flowing and things like that.
Yeah.
I think I was going to ask you. Somebody had emailed me, and they had a defective prolapse valve, and they put in a mechanical one. I thought they used to put in pig valves in there at one time. Is that not done anymore?
So again, this is more cardiac surgery related type stuff. So this gets into the intricacies of valves. So that goes a little bit more complicated and kind of outside, the realm of my expertise. But they do both. They do bioprosthetic valves, which are tissue valves, porcine valves, and then they also do mechanical valves as well. And the reason for that, it depends on certain anatomy reasons and stuff that.
You must have you have valves also in your legs?
Yeah, you have valves in the veins. You have valves in the veins, because if you think about it, the blood that's going from your heart to your legs, to your arms, to your belly, it's being pumped. It's being pumped by the heart, so you don't need valves to get it to its destination. But now the veins that are bringing blood back to your heart, there's no heart pumping those veins back. So the function of the valves is to, when you contract your muscles, pumps the blood up, the valves keep the blood up, and then eventually it goes all the way back to your heart.
And so what is the most common problem you deal with at the Vascular Care Group?
So I would say probably there's a few very common problems. So one is carotid disease for stroke. The other thing we treat is peripheral arterial disease. So anyone who's got pain with walking, claudication, that's another thing. DVTs is another thing as well. We also deal with aneurysms too. So if someone has an aneurysm, meaning enlarging of an artery, a lot of times that's something we see as well. Not so common as these other three things that I mentioned, but we see, again, there's a blood vessel throughout your entire body. So we see all sorts of issues with blood vessels everywhere. We'll see a lot of patients who will just get a CAT scan, they go to the ER, they find something weird with the blood vessel, they'll send them to us, and then it's our job to figure out if it's something to be worried about or not. But the most common thing, peripheral arterial disease, venous insufficiency, which is leaky valves, deep vein thrombosis, DVTs, and then carotid artery disease.
So how would you...
And not to mention dialysis access too. So a lot of patients who will eventually, their kidneys fail and need to be put on dialysis, we do the surgery to basically, we create a fistula or a graft to allow them to go on dialysis.
So how would you treat an aneurysm?
So that's a good question. It depends on where the aneurysm is and the size of the aneurysm. So the most common aneurysm we deal with is called AAA's, abdominal aortic aneurysm. So an aneurysm in the belly. The way we treat that is two real ways. Traditionally, 30, 40 years ago, all the vascular surgeons, they used to do an open operation for this. So you'd cut the belly open and you'd you basically open up the aneurysm and you repair the artery with a graft. We still do that in certain patients. In younger patients, we tend to do that because it's a very durable operation. But now we're doing a lot more endovascular stuff, which means we go through the blood vessels and we put that same graft in through the blood vessels, through a sheath, through a device that we can just deploy, and you don't need a big operation, big incision. And it's great for patients who are older, in their 70s, 80s, who really can't tolerate a huge operation, like an aortic operation. So in those patients, we just treat it through the blood vessels, and they do great. It does require monitoring and surveillance, but they're able to do that.
Now, would it be, I know, again, with the gentleman was in the other room, he was talking about the way they picked up his DVT is they went to the legs and was feeling for the, for the resistance, basically, for the pulse in the leg. And they could find out it was a different pulse here, then it was a different pulse here. Then they could figure out exactly what was.
Yeah, so when they do the ultrasound, they can actually see the blood clot. So when they do the ultrasound, they can see exactly where the blood clot is. So it's an amazing thing, and because there's no radiation to an ultrasound, you're not going to a CAT scan, there's no increased risk of cancer, any of that. And it's a very easy test. You don't even need to go to the hospital. You can go, we do it in our office on a daily basis. In fact, in our Worcester office, there's 3 ultrasound techs who are doing these ultrasounds every hour. So it's such a common thing and such an easy thing to be done.
Yeah, and I think I want to get across to the audience too. You want to catch this stuff ahead of time. The sooner you catch it, the better it is. You don't want to wait, and the sooner you can get it treated, the better it's going to be. You don't want to wait until something really bad happens. So it's a good idea, like I did, just go in, and in fact, I've got it set up at Day Kimball. I'm going to also go in and have an echocardiogram done. Make sure all my valves are working, make sure everything's going with that. So, and again, I have no symptoms. So, but I think it's a good idea, just prophylactically.
I think it's great. I think most, I think any patient who's really, seeing their PCP or their primary care provider, just bring it up to them like, hey, I got this. Can you have me see a vascular surgeon? And usually we, in our office, we try to see patients within 1 to 2 weeks. So if someone needs to be seen, we'll see them that same week or the week after. And the worst thing that can happen is it's nothing to worry about. But
that's the best thing that can happen.
Exactly. I guess that's the best thing. It provides reassurance, So now okay, there's nothing wrong with this. You can sleep at ease. So we do the test in our office. We'll see the patient right after the test, where we discuss the findings. And if there's nothing to be done, then it's great. And if there is something to be done, then we can also treat that as well.
Yes, yeah, so again, you want to catch it. Now, what about varicose veins?
So varicose veins kind of comes back to that leaky valves issue. So when you have these leaky valves, you have this blood pooling. What happens is when the blood pools, your veins, they start to swell and they start to get all, twisty, wiggly, the picture that you see all the time on pictures, those are called varicose veins. So it becomes into varicose veins. And sometimes varicose veins, for a lot of patients, they may just be a cosmetic thing. It just may be something that's not bothersome. They don't have many symptoms. But for a lot of patients, they do have symptoms with the varicose veins. Sometimes patients can have just bleeding. It just starts bleeding all of a sudden. They can get skin changes, or skin starts to darken. They get all these sorts of changes that really affect their quality of life. So the nice thing, again, is there's a very easy fix to treating these leaky valves, and it's called ablation. It's also done in the office. So we bring the patient in, we burn this vein that's causing all this reflux, all this pooling of blood, and then they do so much better after that. The varicose veins disappear, their symptoms improve, and the procedure takes less than an hour. Sometimes it takes 20, 30 minutes. That's the average time. And they're in and out. You don't need to be put to sleep. You don't need a breathing tube. Just come in our clinic, we do it, and you're home the next hour.
Right, and for the listeners, correct me if I'm wrong on this, but there's something called angiogenesis, basically where veins will regrow. Is that what happens with the varicose veins? You're burning it out, another vein will go in there?
No, that's not exactly what happens. So the angiogenesis, when you're referring to, that's the creation of kind of blood vessels. And the body's unique in the sense that if there's a blockage somewhere, it does that angiogenesis, which it creates these natural bypasses. It creates these, for example, the highway's blocked, it creates these new exits, which the body naturally does. So that's what it does when there's blockages in the arteries. So the body tries to fix it on its own. Sometimes it works, most of the time it doesn't.
So you won't necessarily grow a new artery down there?
You won't grow a new vein once your vein is burned.
Yeah,
you won't grow a new vein once your vein is burned. Now, what can happen is sometimes this vein, it opens up again. So, and again, that's a very rare scenario. It doesn't happen that commonly, but we can see that. And again, then you just treat it again. But yeah, the body has a unique way of forming all these collaterals, bypasses. It's pretty interesting. But to the point of angiogenesis, that's actually something that kind of can take us to arthritis, really, because the arthritis pain is because of all the blood supply that supplies, we call it the synovium, which is basically the capsule, your knee capsule. The reason for arthritis is when that gets damaged. So a lot of times when that gets damaged, there's all this inflammation. And when inflammation happens, then angiogenesis happens. All these blood vessels start forming, and all these blood vessels supply the synovium, and that's really what causes the pain from arthritis. So a lot of times, the treatment for it, knee replacement, it's great, but unfortunately a lot of patients, they cannot get that, or they can't tolerate it, or they don't want it for one or another reason. So now this is kind of a newer technology which has been out for, I think, a little over 5 years now, and it's showing great results. We go in through the blood vessel, through wires and catheters, we block off these arteries that are supplying the synovium, the knee capsule, and then in 60 to 70% of patients, their symptoms improve significantly. And it's a very durable thing. So normally people will get injections, shots, all this stuff, but this is a newer technology that we're now offering in our office, in our surgical suite, and then they go home the same day and their symptoms improve.
Right, and you're one of the, and this comes out of, I think it was Japan, right?
Japan, yep.
Japan, came out of Japan. In fact, Dr. Russo was on the show.
Yeah.
The other thing is I've had other orthopedic surgeons on the show, and they tell me that knee replacement is a 90-10 proposition. 90% of the time it's great, other 10% of the time not so great. And you can't undo it once it's done. So it's basically, this is a way. And the other thing that Dr. Russo said, he was surprised because he got a lot of younger people in getting it done, because the knee replacement only lasts X amount of time.
There's a certain life, yeah.
Yeah,
so the goal is to really prolong the time your knee replacement will be good. So for example, if you have a young patient who's, let's say, 40, has arthritis, let's say they get a knee replacement, that knee replacement will only do good for a certain extent of time. Now let's say it's good for 20 years, right? They're probably still going to be alive at 60. Now what? You can't, having a redo knee replacement operation, that's a huge undertaking. So what this can do is buy you time and, fix that pain issue that you're having, maybe lasts, 5-10 years. It gives you that extra amount of time, then you can get your knee replaced. So it has a quite a few different patients that it can treat. Even we've done it for patients who've already had knee replacement and their pain is still there. And then we end up in doing this after, and improves their pain. In
fact, I brought my wife, and we tried everything. We did PRP, platelet-rich plasma, and that didn't really help her. And she's bone on bone. But we saw Dr. Roos, and basically, he said, how bad's the pain? She said, I can live with that. He says, we can do it anytime you want. So even if you're bone on bone, you guys can do it. But the other thing I like about it, it's an in-office procedure, and I think in most cases it's always covered by insurance, which is even better. So, I mean, worst case scenario, I mean, for whatever reason, if it doesn't work, you always have the knee replacement afterwards if you needed to. So I would do, I want to do the least invasive thing possible that it doesn't have to reverse to somewhere down the line. So. Yeah, anybody out there, I see a lot of clients, and the big issue is again, a knee is a big thing in terms of you can't sleep at night, you can't get around, and everything else. So if you can just relieve that pain in terms of that. And how long would it normally last, just like for the average person?
So if we do this embolization, I mean, in some patients, their symptoms improve kind of within 4 to 6 weeks, and then it may last years after that. Sometimes patients need to come back and again have this repeat thing done where we take a look at some other blood vessels if they're still having these symptoms and stuff. But the way I see it, it doesn't preclude you from having an operation, so it's great. The complication rate is minimal. It's a same-day procedure, and a lot of insurance companies are covering it now because they're seeing these promising results. And then let's say you still need a knee replacement, you can still get that done. Right?
But you can't do the reverse. You can't get the knee replacement and then go back to this.
Well, you can get the knee replacement, and then we can even do this after the fact as well.
Right,
and
so if you're still having the pain for whatever reason, you can get it done.
Exactly.
Okay, so we're coming up to the end of the show. So how can they reach you?
Yeah, okay. Well, I mean, there's so I see patients and my partners, see patients in Worcester, but do you want me to say out the
Sure, yeah.
yeah. So our office number is 508-556-0223 for anyone who wants to, schedule a meeting with us and talk about vascular disease. And I see patients in Worcester. My partner, as you mentioned, Dr. Roos, sees patients in Worcester as well. And there's another partner of mine who also sees patients there. But we see patients also in Sturbridge as well. So we'll see patients 4 days a week in Sturbridge. So anyone who lives closer to this area, we can see them there. If not, then they can come to Worcester and we'll see patients there. Yep.
Yeah, you can just email me, philgeorge@charter.net. If you get all this stuff, I can shoot it right over to these guys. Okay, so again, it's important. They got to take care of the carotids. Okay, so thanks so much for coming on, and we'll see you guys next week.
Absolutely. Thank you for having me.
One of the most common questions I'm asked as a biochemist and health coach is, what are the best supplements to take? Choosing supplements is a tricky business. Many companies have poor quality control and questionable ingredients. In the past, I had to send clients to several different websites. I am now able to offer one-stop shopping for all the quality brands I recommend with no shipping cost and a lower price in most cases. Just email me, philgeorge@charter.net, for a free consult.